All right, hello everyone. Can you hear me okay? Yeah. All right, we are about to get started. I am Lance Archer and I will be your moderator for this plenary session. This time we are going to be introducing our first speaker, and we have Dionne Sinclair is an accomplished certified. Sorry?
Andrea.
Oh, okay. I'm sorry, I had it in the opposite direction. I apologize. All right, so Dr. Andrea Cervi is an adult hematologist practicing at Windsor Regional Hospital in Windsor, Ontario, where she serves as the division head of the thrombosis department. She obtained her Master's of Science in Biomedical and Molecular Sciences at Queen's University, followed by her MD at the University of Ottawa, and Internal Medicine and Hematology training at McMaster University. Dr. Cervi has a mixed malignant and non-malignant hematology practice based entirely at the Windsor Regional Cancer Program. And she will be presenting to us on the science behind oral versus infusion opioid therapy. Please welcome Dr. Cervi.
Okay, hopefully everyone can hear me. So thank you so much for the opportunity to speak, and thank you to SCAGO for inviting me. My disclaimer is that I'm a hematologist and I'm not a pain medicine specialist, but I'm going to give it my best with this talk here. Can we go to the next slide, please? So just to sort of set the basis for the discussion about opioid therapy and sickle cell disease, we know that pain is the most common complication of sickle cell disease, and that pain is quite multifaceted and have different etiologies, but one of the more classic causes of pain that we know in sickle cell disease is that sickled hemoglobin, when in a relatively deoxygenated state, can produce changes in the red cell membrane to a... Oh, I'm sorry. Is that a little bit better?
Or projector.
Okay, all right. We'll hold it up here. Just wave your hand if you can't hear me in the back there. But those sickled red cells then can go on to cause polymer aggregation in the small blood vessels, leading to tissue death and inflammation, and that's classically perceived through different mechanisms as pain. Next slide, please. 50% of adults with sickle cell disease do report pain on more than 3 days per week in certain studies, and we know that about 40% of adults report taking opioids on a daily basis. And despite this, about 30% of individuals would still say that they do experience significant pain, and that could very potentially be an underestimate there. Next slide, please. Although we do tend to focus a lot on sort of nociceptive mechanisms for pain, the classic sort of red blood cell clogging of the microvasculature causing inflammation and ischemia, we know that pain is actually quite complex and due to different etiologies. And so there's large elements of psychosocial trauma that can contribute to the perception of pain due to depression and anxiety. Other acute stressors, sleep deprivation, can also contribute to the perception of pain. And then there are neuropathic mechanisms that do tend to cause sensitization of the nervous system that can also contribute to the different phases of pain in sickle cell disease. Next slide, please. We also know that there's different tempos and patterns of pain in sickle cell disease. So we do tend to focus a lot on acute pain episodes, because that's often what causes an individual to seek out acute medical attention. But as was said in a few slides earlier, several individuals do experience pain on a daily, regular basis, leading to chronic pain. And then there are acute on chronic pain episodes that are different from acute painful episodes as well. All of these patterns of pain, of course, can contribute to decreased quality of life in patients with sickle cell disease. Next slide, please. Opioids remain the mainstay for treatment of pain in sickle cell disease, especially in acute painful episodes. Next slide, please. So many guidelines, the most recent would be the American Society of Hematology in 2020 issued different guidelines on managing different elements of sickle cell disease related care. But in their guidelines on acute and chronic pain management, their first recommendation actually relates to the very rapid assessment and early administration of pain medications for patients presenting to the emergency departments. And they go on within their body of their guidelines to say that often the sort of panel, when weighing the benefits versus harms, did favor the very rapid initiation of opioids with very frequent reassessments of the pain medication that they're getting from an opioid perspective, really favoring an individual or tailored approach. Next slide, please. So how do opioids work? I will admit that this is a bit of an oversimplification, but opioids bind to receptors that are disseminated throughout the body, but particularly within our peripheral and central nervous system. And broadly speaking, there are three different types of opioid receptors. There are mu receptors, delta receptors, and kappa receptors. Most opioids are exerting their effects by binding to mu receptors. Next slide, please. So one of the most common examples of mu receptor agonists that we would know of would be things like morphine and hydromorphone or Dilaudid and oxycodone. Next slide, please. So there's three main ways that opioids, through binding to the mu receptor agonists, can exert their analgesia or pain effects. So opioids first can act at the peripheral nervous system, so they can actually block the activation of pain-sensing neurons when there is an acute event that's sort of triggering those signals to go from the periphery through the spinal cord and then perception through the brain. Opioids can also act at the level of the spinal cord to actually, again, block the transmission of pain pathways from the periphery up to the brain. And then opioids can act at the level of the brain to block the perception of pain as well. And sometimes that can actually, over time, lead to a little bit of hyperalgesia or altered sensations of pain as well if opioids are not sort of tailored appropriately. Next slide, please. So the effect that an opioid has actually depends on how it enters the body. Next slide, please. So opioids taken by mouth are first absorbed by the intestinal tract, and then they undergo their first pass metabolism through the liver, and it's through those metabolites that then are able to bind to largely the mu receptor agonists throughout the body to exert their pain effects. Opioids taken intravenously end up having their effects much more quickly because they're avoiding that first mass metabolism, although ultimately those metabolites are still going through the liver and kidneys to differing options. But essentially, when opioids are coming in intravenously, they're acting much more quickly than opioids that are taken by mouth. Next slide, please. So I have a chart of some of the more common oral opioid options that most people would probably be most familiar with. So IR stands for immediate relief there. So morphine, typically when taken in the immediate release form by mouth, is exerting its effect within about 30 minutes. And that's the case for different types of oral opioids generally, is that usually within anywhere from 15 to 30 minutes, they're having their main effect. They all have different half-lives and different durations of pain effect or analgesia within the body, typically ranging between 3 to 5 hours. And then each does have their own metabolism pathway and their own byproducts that can lead to other side effects. So morphine can have more histaminergic effects, and that's why we know that sometimes when we give individuals morphine, they can get a lot more pruritus or more allergy types of symptoms as well, and that's sometimes due to the byproducts of the metabolism and their ability to act on other histamine receptors too. Next slide, please. Many of these oral options come in intravenous form too. I did add fentanyl here as another intravenous form that we can see, but as we're seeing, the peak effect for the intravenous opioids is happening a lot more quickly quickly. So when we were looking at oral, oftentimes those effects were within about 30 minutes. When we're looking at intravenous delivery, those peak effects can be anywhere from 5 to 10 minutes. Typically a same duration of effect, although fentanyl's a little bit different because it has a wider distribution throughout the body. It tends not to last as long, so it can be delivered a little bit more frequently, but typically a same duration of effect. Next slide, please. There's also different modes of delivery of intravenous opioids, and so one of the modes would be patient-controlled analgesia, or PCAs, and that's actually when individuals are attached to a pump to some degree, and there can be a basal or continuous infusion that's delivering a constant amount of opioid, and then patients themselves have a little remote control, and that can deliver a pre-specified amount of additional opioid at a certain lockout rate. A lot of times these patient-controlled analgesia pumps are given together with things like morphine or Dilaudid or sometimes fentanyl, but there are lots of different combinations that can be used, and there can even be a different opioid that's given as a continuous rate, different than what the patient's actually able to deliver through bolus. It's very center dependent, I think it can be. Next slide, please. That's just another picture of what it looks like in real life, so it's got a cool little remote control that you can see there. And then the different sort of settings that can be agreed upon with the patient and the physician. Next slide, please. Probably the most common way that we're seeing intravenous opioids used is through an intermittent clinician bolus, which is just a regular prescription of a certain dose, sometimes a dose range that's given at a certain rate. And then there are continuous infusions, which again can be center dependent, but a lot of times I know in our hospital for intravenous infusions of opioids, typically our staff wouldn't feel comfortable doing that on a regular ward. That would be given in an ICU or a higher level setting, just for the potential for more side effects. Next slide, please. So I think there are a few additional notes to make about use of opioids in sickle cell disease. It's not a one-size-fits-all. It's a very individual and tailored approach, and we know that some individuals with sickle cell disease can metabolize opioids very differently, and that can lead to differences in sort of analgesia effect, along with differences in potential side effects and adverse effects that we can see. And although there are lots of guidelines now, I guess I shouldn't say lots of guidelines, but although the guidelines would advocate for use of opioids in the management of pain for sickle cell disease, there's actually very little in terms of what the ideal opioid, what the ideal administration rate, and really how we should go about coming up with an individual tailored approach. So aside from saying that opioids sort of remain the mainstay, we don't have a lot of additional help or guidance from the literature to go beyond that. There is the potential for individuals who do have chronic daily pain, if their opioids aren't reassessed or tailored, then that can make acute pain management a little bit more challenging sometimes. And then the last thing that I'll say is that we do know that an effective comprehensive pain approach relies more on just an opioid, although that's sort of the topic that I was given today, and non-opioid adjuncts, not even from a pharmacologic, but from a non-pharmacologic perspective, are very crucial to addressing pain as well. And that's the end of the talk, so thank you so much for your attention.
Thank you so much.